great to be here and have the honor of being the last speaker, so I have to try and keep everyone awake. The Argentine Society of Cardiology and the Argentine Federation and the ACC were all nice enough to include me in this, and I thank you very much. While we're waiting for the slides to get up, I remarked when listening to Dr. Sperling's lecture on risk, it reminds me that we always tend to underestimate risk when we don't use these calculators. And what reminds me of that is how many people in the audience have credit cards? Raise your hand. We all do. How many people get a bill that comes to you once a month? And right before you open that bill, how many people have an idea in their mind of what the amount of money is going to be? When you open the bill, is it ever less? It's never less, right? It's always more. And I think that's the way we have to think about risk, which is why using these scoring systems is very important. But they're a start. And that kind of leads right into my program here. This is correct, so we'll open this up, where we're going to talk about guidelines. And just like risk scoring algorithms, guidelines are a starting point. They're not an ending point. And if you're following guidelines, which I hope we all are, you're doing the bare minimum. Guidelines are created so we are all practicing the basics. And then we can go from there and individualize care. But remember, guidelines are population-based, and they give us guidance. And so again, this presentation is also supported by a grant from Pfizer, and again, through the American College of Cardiology, the Argentine Federation of Cardiology, and the Argentine Society of Cardiology. And these are my disclosures. So the objectives here are to improve implementation of guidelines, to create evidence-based management strategies for our patients, and then discuss clinical care plans for comprehensive lipid-lowering therapy and primary prevention, understanding that even myself, as a lipidologist, does not practice in a vacuum. And while I believe lipids are important, I spend my life in this field, you can't look at lipids and lipid management out of the context of other cardiovascular risk factors, and we do that all the time. So the rationale for guidelines in ASCVD prevention, I think, is very key and important. But before we get into that, I want to go through a ARS question. Which of the following statements reflects your use of ASCVD guideline recommendations? I'm not familiar with the data supporting the 2016 Argentina ESC-EAS or 2013 ACC-AHA guidelines. I do not have time to follow guidelines in my practice. I do not agree with all of the guideline recommendations. I try to follow them. I try to follow ESC-EAS guideline recommendations. I try to follow ACC-AHA guideline recommendations. So the results should be here. So the majority are 4. I try to follow the 2016 Argentina clinical practice recommendations, or 29% with 6. I try to follow the ACC-AHA guideline recommendations. What's good to see is the majority of people, again, like the risk estimators, are here following guidelines or utilizing guidelines in the management of their patients. Yet when it comes to the rationale for guidelines, it's important to remember that while we have foundational recommendations for practice, they're based on decisions for clinical evidence. They emphasize randomized controlled clinical trials and are meant to distribute knowledge written by experts. A variety of evaluations, including this one by Salim Varani and his colleagues, published in the Journal of Clinical Lipidology, suggest that there is suboptimal implementation of our guidelines. Now, why does this happen? Well, awareness, right? You have to actually read them, and not just read them in the lay media, but actually understand the complete degree of how they have been described. Lack of agreement with guideline recommendations. Not everyone agrees with everything that's written. Clinical inertia, right? Actually getting started with them or utilizing them. And then finally, cognitive overload. Often there are competing guidelines, more than we need to actually be able to assimilate with regards to the management of our patients. So when we address modifiable targets in primary prevention, I actually do believe that LDL is causal in ASCVD. Lipidologists no longer use the term LDL hypothesis. There are a variety of very clear lines of evidence that establish the role of LDL in the causality of ASCVD. We have epidemiologic data, lots of good observational data confirming the association with increasing or decreasing LDL levels and similar event rates for ASCVD. We have experimental models, mostly animal data, showing that as LDL increases, atherogenic burden accumulates, and as we reverse that, we can actually reverse atherogenic disease burden. We have therapeutic interventions where lowering LDL safely is associated with the reduction in ASCVD events. And then finally, most compelling, I believe, is the new accumulation of genetic evidence, both genetic and genomic data, showing us that mutations that associate with increased or decreased LDL levels similarly track with lifetime benefits or decreases in ASCVD event rates. And a lot of this comes from some new data that we've seen over the last couple of years. The etiologic role of LDL cholesterol in the pathogenesis of ASCVD is established very nicely by a variety of landmark clinical trials showing that LDL cholesterol is strongly associated with risk, and interventions that decrease LDL cholesterol decrease the risk of ASCVD events. And here you see a variety of statin trials, some of these primary, some of these secondary prevention, some of them combination like heart protection study, all again depending on the degree of LDL lowering, the risk of the patient, and the actual level of the LDL is what actually determines the change in absolute risk in the patients. Lowering LDL reduces ASCVD across a variety of patient cohorts, and when we look at meta-analyses of these, you can see that LDL cholesterol changes of about 1 millimole per liter result in a reduction of about 20 to 25% in major cardiovascular events. Now again, this is relative risk reduction, but Larry was talking earlier about absolute risk and how important that is. And when we look at absolute risk reduction in patients in lipid-lowering trials, it's really related to three things. The absolute risk of the patient. The higher the risk of the patient, the greater they benefit. The second is the absolute change in LDL cholesterol. How much does LDL change? Not percent, but the absolute change. And then finally, it's how high is the LDL cholesterol. The higher the LDL, the greater the change is. So again, if you're going to alter any of these and make them less significant, such as if the risk is lower of the patient, the change has to be greater. Or if the LDL is lower, the risk has to be greater for you to accrue the same absolute changes in LDL cholesterol. So current guidelines for managing ASCVD risk, well, we've got a lot of them, and we'll talk about them. But first, I want to do another ARS question, which is the following. The 2013 ACC-AHA Cholesterol Management Guidelines recommend discussing statin therapy with which of the following patients? Without CVD or diabetes, age 40 to 75 years, with advanced heart failure, without CVD or diabetes, aged 40 to 75 years, with 10-year ASCVD risk less than 5%, without CVD or diabetes, age 40 to 75 years, with 10-year ASCVD risk greater than 7.5%, or without CVD or diabetes, age 40 to 75 years, with end-stage kidney disease on dialysis. So we'll count down now and have you answer these on your keypad. Okay, and we'll see the answer here. The correct answer is 3, right? Without CVD or diabetes, 40 to 75 years, with a pooled cohort estimate of ASCVD risk greater than 7.5%. Several people chose here less than 5% or end-stage kidney disease, and we'll go through that in a little bit just to clarify it. But it's interesting, when you look at the accumulation of guidelines, it's encouraging to me to know that the United States is not the only place where we have a plethora or accumulation of these guidelines. And so we have the 2013 ACC-AHA guideline, and then After that, the European guidelines were published in 2016. EAS-ESC guidelines were published right after that, followed by our own National Lipid Association recommendations in the United States. And then you also have competing guidelines here in Argentina. And none of these are better than any other, just like the calculated risk scoring systems. They're just different. But they have far more in common than they have different. And I think that's the key thing to remember about all of these guidelines and recommendations. So what do we look for when we think about guidelines? I always say the commonalities. The concordance in these guidelines are really what holds them all together and makes them all relevant and appropriate for our use in clinical care. Lifestyle is the foundation of all of these. Healthy lifestyle and implementing changes in lifestyle if they're not healthy. The etiologic importance of LDL-related ASCVD risk, and I showed you the lines of evidence for that. The intensity of therapy should be matched to the risk. Every one of these guidelines and recommendations says the higher the risk of the patient, the more intense the therapy should be. Statin therapy is the mainstay. The number one step in pharmacologic interventions for all of these starts with statins. Why? They work, they're safe, and in most cases they're inexpensive. Response to therapy should be monitored, right? If you don't know whether or not a patient responded to the therapeutic intervention, you can't know whether or not they will benefit. That's been clear over and over again. It's not just the prescription of the medication, but it's the appropriate response to the medication. And so inadequate therapy needs to be addressed, either by changing medicines or adding medicines or addressing things like non-compliance or adherence. And then finally, non-statin therapies may be considered in appropriate high-risk patients. So guidelines are not rules. They're a starting point. Clinical judgment is key, and I think this is the most important thing I can tell you. Pick a guideline and implement it. Pick one, you got to know what they are. Choose the one that makes the most sense for you and the patients you're caring for. But key, again, is healthy lifestyle. It's the foundation of ASCVD prevention. DASH diet, Mediterranean diet, reducing alcohol consumption, moderation advised, physical activity, weight reduction if someone's overweight, and yes, smoking cessation and not starting if someone doesn't smoke. Lifestyle can reduce atherogenic cholesterol by 10 to 15%. These are the Argentine Lipid Society guidelines, very much similar to what I just showed you now. Weight reduction, psychosocial factors, depression, stress, isolation, and rage all play a key role, as Dr. Sperling mentioned earlier, and controlling non-lipid risk factors are also similarly important. So when we look at the tenets of the lipid-lowering therapy in the 2013 ACC-AHA blood cholesterol guideline, statins are the cornerstone. Absolute risk reduction is the key criteria. There are 4 statin benefit groups. Primary prevention, which is what we're going to focus on here, initiate a statin if the 10-year ASCVD risk is greater than 7.5%. You may consider it if it's between 5 to 7.5%. And then lipid-lowering therapy needs to be individualized. And so here again, primary elevations of LDL greater than 190. This is essentially inherited lipid disorders or familial hypercholesterolemia. One could consider this primary prevention because these patients may not have ASCVD, but we don't do a risk calculation in these patients because inherent in the diagnosis of high LDL cholesterol greater than 190 or familial hypercholesterolemia is inherently high risk. Patients with diabetes without ASCVD are at increased risk, and they need to be started on statin therapy. And those without ASCVD or diabetes whose 10-year risk is greater than 7.5%, again, meet this criteria. Now, if we look at your own lipid guidelines published in 2016, I'm not going to go through this in detail because I suspect you all know it much better than I do. But again, key to this is risk assessment, and then focusing the intensity of statin therapy on the degree of risk. The higher the risk of the patients, the more intense the therapy, and the greater the degree of lipid lowering achieved. So what percentage of LDL cholesterol reduction would you expect from low, moderate, or high-intensity statin according to the 2013 ACC-AHA guideline as demonstrated in randomized clinical trials? So low, less than 20%, moderate 20 to 39, high greater than 40. Low, less than 20, moderate 20 to 34, high greater than 35%. Low, less than 30, moderate 30 to 39, high greater than 40. And low, less than 30, moderate 30 to 49, high greater than 50%. So we'll count this down. So the majority of people picked either 3 or 4. Low, less than 30, moderate 30 to 39%, high greater than 40. Really high is greater than 50% here, okay? So low, less than 30. So statin benefit group, this is the way we think of them. Clinical ASCVD, LDL greater than 190, high or moderate. Diabetes or 10-year risk primary prevention greater than 7.5%. Again, intensity of statin therapy. High or moderate to high with a heart-healthy lifestyle is key and important when thinking about LDL-lowering therapy and the intensity of the statin therapy. So again, focusing on the primary prevention group or the diabetes, no ASCVD, these are the primary prevention groups we're concerned about. And when we think about them for the diabetes groups, moderate intensity or high intensity, again, based on a pooled cohort estimate. If it's greater than 7.5%, the diabetic patient should be started on a high intensity statin. In primary prevention, no diabetes or no high LDL greater than 190, again, do a pooled cohort risk estimator. And again, in those who are higher, greater than 7.5%, or those between 5 and 7.5%, consider either moderate or high intensity statin therapy. And this just breaks it out to you, makes it a little clearer based on the algorithm I showed you. Diabetes and primary prevention, pooled cohort estimator, and then adjust the intensity of the statin therapy to the degree of risk of the patient. What about triglycerides? We heard a very eloquent discussion earlier about the role of hypertriglyceridemia and dyslipoproteinemia, low LDL, low HDL, and high triglycerides, and increased atherogenic or ApoB-containing lipoprotein burden. And when thinking about managing these based on your Argentine guidelines, again, thinking about things we can change, exercise, weight reduction, carbohydrates, and alcohol, and then instituting agents that lower triglycerides when triglyceride levels are high, but also thinking about cardiovascular risk in these patients, as evidenced by those who have low HDL cholesterol and high triglycerides. And these patients, again, need to have their atherogenic lipoprotein risk addressed, either by statins or sometimes triglyceride-lowering agents. So the lipoprotein targets of therapy in the 2013 ACC-AHA guideline are really the intensity of statins, right? We know that high intensity will lower LDL about 50%, moderate between 30 to 50%, and low less than 30%. So the randomized clinical trial evidence does not necessarily support LDL cholesterol or non-HDL as specific targets, which is why the focus of this guideline was on the intensity of statin therapy. So again, when we look at the algorithm and we talk about lipoprotein goals, what are the goals? The goals are really the intensity of statin therapy. Why? Because you want to achieve the appropriate reduction. I told you that absolute risk change is related to the absolute change in LDL, which is why you need to use the appropriate intensity of statin therapy. This is why before these guidelines were written, you had a patient who had a heart attack and their LDL was 94. Larry remembers this. Pam, you remember this. People will try to lower it from LDL of 94 to 70. That doesn't really move the bar enough because the absolute change in LDL hasn't been achieved to associate with the risk reduction that you're trying to accrue, which is why intensity of statin therapy, even in primary prevention here, is so key. So matching intensity of risk-reducing therapy to absolute cardiovascular risk is one of the key tenets of how we think about risk reduction in the context of LDL lowering. These, again, are your high-intensity statins, Atorva 40 to 80, Rezuva 20 to 40, and these are your moderate-intensity statin therapies. So the role of non-statin therapies in ASCVD risk reduction, I think, remains important. Statins are typically safe for long-term use. Muscle-related symptoms and diabetes are known. They're uncommon, I think, adverse events, though. They don't really impact our ability to manage patients successfully over the long term because we have other options now. And so non-statin therapies can be considered in certain statin-intolerant patients or in patients with inadequate response. And you heard earlier about the IMPROVE-IT trial where ezetimibe was added to simvastatin in patients at high risk post-acute coronary syndrome with multiple other risk factors. And while a benefit did accrue over 7 years, it was mild, right? It was a small benefit. The number needed to treat was 50, but it was over 7 years. And these patients were treated at the low end of the LDL cholesterol curve. So now we have data with PCSK9 inhibitors, evolocumab in the Fourier trial. Fourier trial was a global trial, including almost 300 patients from Argentina in this particular trial. PCSK9 inhibitor evolocumab was added on top of statin in patients with stable coronary disease, and their LDL changed about 60%. The absolute change in LDL was 60 milligrams per deciliter, interestingly enough. They went from 90 to 30. The primary endpoint in the trial was a total MACE, or major cardiovascular events. It showed a relative risk reduction of 15% and an absolute risk reduction of 2%. This doesn't seem that large, but the amount accrued was only over about 2.5 to 3 years. And if you compare this to the cholesterol treatment trialist curve and you adjust it for 4 to 5 years, it falls exactly on that curve. Landmark analysis shows that as you follow the patients out after 1 year, the relative risk reduction is actually greater, up to 25%. And these curves seem to at least continue to separate over time, which led to the update in 2017 of the 2016 ACC expert consensus decision pathway on the role of non-statin therapies for LDL cholesterol lowering in the management of atherosclerotic cardiovascular disease risk. This was a wonderful document published by the ACC. Pam Morris was one of the co-chairs or on the writing committee of this, and the National Lipid Association endorsed this document. And I'm going to pull out two groups that were of the many groups in this document that they looked at. The primary prevention, high-risk patients. So primary prevention in patients with diabetes, manage them through traditional lipid-lowering algorithms, but once you have actually done all of the standard therapeutic interventions and you have not achieved a reasonable reduction in LDL cholesterol, which is either greater than 50% or an LDL cholesterol, in this case, less than 100 milligrams per deciliter, then you would actually consider moving on to a non-statin agent, which would be ezetimibe. In addition, in patients' primary prevention here without diabetes and a 10-year ASCVD risk greater than 7.5%, you would see a similar progression after optimally or maximally tolerated statin therapy to a non-statin therapeutic intervention, which would be ezetimibe. What you don't see here yet is the utilization of PCSK9 inhibitors. They are reserved for patients with ASCVD or familial hypercholesterolemia, and we're focusing here today on primary prevention. So when it comes to putting risk management into practice, I'm just going to end with one slide because Dr. Sperling really summarized this beautifully, and it's the importance of shared decision making and letting patients understand, A, what their risk factors are, right? Just because you have hypertension, smoking, and obesity doesn't mean the intervention has to be a statin. It might be treating the hypertension, improving the obesity, and stopping smoking. So having that shared discussion is a discussion about the risk factors as much as it is about the risk benefits of the intervention that you might be proposing to your patient. And so again, Patients want to take an active role in their treatment decision, and shared decision-making hinges on the two-way communication between the practitioner and their patients. So areas of concordance, again, I went through this. There are far more in common with guidelines than are different, and so for that reason, you need to pick a guideline and implement it. So the summary would be that global guidelines recommend statins as first-line agents. Non-statin therapies may play a role in select high-risk patients when response to maximally tolerated statin therapy is less than anticipated. Follow-up LDL monitoring is important and key to adherence and also to achieving the degree of risk reduction you believe is appropriate for that patient. And shared decision-making and clinician-patient discussions are key to initiating and the success of these processes. Thank you very much.